We're live.
Okay. A very good afternoon to our guests that are here today and will be talking to us later on. And to you, those that have joined our webinar series, a huge welcome. Before I start with anything else, I would like to include just some housekeeping notes for everyone just to take note of. We reserve the right to remove any participant whose behavior causes any disruption. The event is broadcast on our Protect Our Next social media channels and can be followed there as well. Please do follow our social media pages for regular updates. Please put all your questions in the Q&A box during the webinar. We will have a question and answer time at the end of the program. You will find all the information you need about the Protect Our Next Tobacco Control Conversation series at www.protectournext.co.za. There is also an opportunity to sign up to a tobacco control champion in the African region, so please do join that group. I would also like to say a warm hello from my co-host, who is Professor Pamela Naidoo, and she's based in the mother city of Cape Town. And me, Lorraine Govender, from the CANSA Association and based in sunny KZN. I would like to just give you a brief overview of what is our role and why the CANSA Association is part of this important webinar today. As many of you may know, tobacco use remains the leading cause of preventable cancer deaths. On average, people who smoke die about 10 years earlier than people who do not smoke. And most people know smoking can cause cancer. Smoking causes about 20% of all cancers. About 80% of lung cancers, as well as about 80% of lung cancer deaths, are due to smoking. Lung cancer is the leading cause of cancer deaths in both men and women and features among the top 5 in South Africa. Smoking can also increase your risk to many other cancers, like cancer of your mouth, larynx, which is your voice box, pharynx, your throat, esophagus, kidney, cervix, liver, bladder, pancreas, stomach, colon, or rectum, and also increases your risk of myeloid leukemia. So given this background, we are pleased to be working with partners like the South African Medical Research Council, the Heart and Stroke Foundation of South Africa, National Council Against Smoking, who are core organizations behind the Protect Our Next campaign, together with other organizations involved in tobacco control at grassroots level. Research has shown us that stricter legislation has a direct influence in bringing down the smoking rates nationally and throughout the world. Today, we are pleased to have a panel of speakers who have been pioneers in the fight against tobacco control in our country. And they will educate you on the harms, on the legislation, on what has taken place in South Africa. But before I continue any further, I'd like to allow us to have an opportunity to view a video. Thank you.
3 years ago, a group of South Africa's leading health organizations, including NCAS, CANSA, the Heart and Stroke Foundation, and the South African Medical Research Council, formed an alliance through a partnership called Protect Our Next, with the sole goal of really improving the tobacco control legislation in South Africa. The current legislation we have is out of date. It doesn't include e-cigarettes. There are various changes that need to be made to better protect children, for example, not smoking in cars with kids under 18 versus under 12, not smoking in creches and childcare places, as well as broader measures to create smoke-free environments. And that basically will protect those who don't smoke and also just make it more difficult for smokers, which ultimately is what we need for a healthier life. So what we're doing today is meeting the women behind tobacco control, the women and men.
Speaking to the youth is very important, especially a campaign like this that's fun and doesn't sound like doom and gloom all the time. You know, I get so tired of the doom and gloom. So for me, it's like the youth need to understand that as much as it's represented as cool to smoke and hold one of these little vape things and blow all the smoke and all the flavors, it's not cool to end up in hospital. It's not cool to end up being so ill that you don't get to live your young life anymore. And you want to see yourself grow. You want to see the future, and cigarettes are not going to do that for you.
We also know that when you work with a team and with a group, your voices are so much more stronger. We are therefore very, very thankful for the opportunity to work with other partners in ensuring that we have more push for the bill and more voices to be heard.
So the importance of it is that the youth will be able to push the bill. The youth will be able to be in the forefront of the campaign. And the reason I'm saying is because as a network, we've got more than 7,500 members that are actually radical, but also understand the importance of this bill and also understand the importance of this campaign.
The key purpose is to reduce cardiovascular disease in the country, on the continent of Africa and also around. And so it's really important for us to work together to mobilize not just professional people, but also the public at large, to get them to understand the importance of the tobacco bill and include other electronic devices as well, so that we can protect all South Africans.
Should I go ahead, Lorraine, or are you going to introduce me?
Okay. Thank you. I will now hand you over to my co-host, who is Professor Pamela Naidoo from the Heart and Stroke Foundation, and she will tell you a little bit more about herself. Thank you.
Thank you so much, Lorraine. A very good afternoon to everyone on this webinar today, particularly to our consortium of amazing organizations that help mobilize to reduce the harms from tobacco, but more importantly, to push the tobacco bill into law. So, you know, the Heart and Stroke Foundation South Africa, you can go ahead and read about our mission and vision on our website. However, I think it is important for me to tell you directly the harms from tobacco on cardiovascular health. Now, I think that the way I'm going to illustrate this is by telling you that in 2018, the World Health Organization's theme for World No Tobacco Day was indeed tobacco breaks hearts. I think that is really classically telling you that the World Health Organization takes the harms from tobacco and tobacco products on all health, but in particular cardiovascular health, pretty seriously. So if you really want to know a little bit of the background on the statistics, smoking triples the risk of having a heart attack and doubles the risk of having a stroke. Now, cardiovascular disease, which includes heart disease and strokes, is the single most cause of death in many countries. Even people who smoke fewer than 5 cigarettes a day may show early signs of cardiovascular disease, with the risk of heart disease increasing with the number of cigarettes smoked per day and duration of smoking. So it's showing you a dose response, in other words. Exposure to secondhand smoke also causes cardiovascular disease in non-smokers, very importantly. As acknowledged by Professor Ntobeko Ntusi, who's a cardiologist himself, as well as the chair of the Department of Medicine at the University of Cape Town. And perhaps to further illustrate the harms from tobacco smoking is that we should all know that 1 in 8 deaths globally are tobacco related. Twice as many women in the world die of exposure to secondhand smoke as men do. An estimated 600,000 women died from secondhand smoke-related deaths in 2016. More men smoke worldwide, but many women get exposed to smoke from their partners within the household. So, just to reiterate that cigarette smoke exposure increases the risk of heart disease, heart attack, stroke, heart failure, peripheral arterial disease, and atrial fibrillation. Evidence suggests that there is a distinct direct dose-dependent relationship between cigarette smoke exposure and risk of CVD. Prof. Nthuzi goes on to say, though, on a more positive note, the risk of cardiovascular disease is rapidly reversible, and stopping smoking following a heart attack reduces an individual's risk of heart disease by 36% in 2 years. So that's a pretty dramatic turnaround time. So despite the decline in smoking rates since the introduction of the anti-smoking legislation and taxation in South Africa, cardiovascular disease remains the second biggest killer in the country after HIV and AIDS and tuberculosis. So we certainly do need to address this modifiable risk factor. And smoking by far is the strongest risk factor and predictor of heart disease and strokes. Perhaps I want to leave you with the following quotation from Professor Salim Youssef of McMaster University in Canada. He goes on to tell us that, he's quite famous or infamous for his work in the Pure study. And, we make a lot of we mobilize around salt reduction, for example. And Prof. Youssef tells us that we can talk about salt reduction, but unfortunately, we cannot talk about tobacco smoking reduction. Ultimately, we need to really work towards tobacco cessation and to then completely eradicate tobacco smoking and its ill effects from at a population health level. So thank you, Lorraine, and once again, welcome to everyone. I'm going to now introduce one of our very renowned speakers, Professor Anthony Westwood. Professor Westwood, thank you so much for agreeing to be a part of our program. I'll just tell you a little bit about Professor Westwood. Professor Westwood practiced as a pediatrician in the public sector until his retirement in 2019. He continues to teach child health at the University of Cape Town, where he works on the Maternal and Child Health Education Project and is the co-convener of the Postgraduate Diploma in Community and General Pediatrics. His area of particular interest are long-term health conditions in children, child public health, health education, and health services for children. He is speaking to us about smoking, secondhand smoking and vaping, the impact on our health and our children. Thank you so much, Professor Westwood. On to you. Thank you.
Thank you very much. I'm going to put up my slides and then we will be ready to go. I don't know whether you can see me, but I'm trusting that you can. But I'm going to share my screen now.
Yes, you're very, very clear indeed.
Good. Well, now I'm going to put up a slide that shows something that's not very clear, and that is a big lot of smoke. So let me just wait till that comes as a full screen. So is your screen, everybody, you don't have to answer, now full of smoke? Well, if you just add a few mirrors, and then we know we're talking about tobacco control, because it is a very complex area in which there are many people who are trying not to protect our next, but actually catch our next. So I'm going to be talking today about the following. I just revealed myself: smoking, nicotine addiction, and secondhand smoke. I dropped vaping out of it because it's not a term that one really wants to use, because it sounds like something rather fun to do, whereas actually all it is using an electronic nicotine device to get your hit of nicotine. And it's not really something that a term that we would like to encourage us to normalize. So if you look on this picture here, we have a number of reasons why we continue to have issues here. We have nasty nicotine, a highly addictive substance that I'll come back to talk about at the moment, which is in all these products, in tobacco-based products, and most of the products that have got other names that I ran through a moment ago. We have a tobacco industry that is set on interfering with tobacco control. And the result is that we have an atmosphere, if you look at the children going in the car here, we have an atmosphere in which children and teenagers and adults are exposed to damaging substances that can have lifelong effects on them. So I'm going to cover here, if we don't move on with the bill, if we don't move on with societal change, if we don't make it every one of our jobs to reduce nicotine and tobacco exposure, and as Prof. Naidoo said, get rid of it altogether in this country, we are going to have a future with tobacco and nicotine. So I'm going to chart this future. I'm a pediatrician, so I think about children from the time that before their mothers conceive them, before their fathers have them as a little thought in their heads, right through the pregnancy and right through life. So as a pediatrician, we don't think of the child as just now. We do think very hard about the child and making sure they have a good quality of life and stay well. But we're thinking right through to their adulthood and their old age and wanting to preserve their health and well-being all the way through. Well, a future with tobacco and nicotine, a future with tobacco and nicotine, which will happen to us in South Africa unless we continue to be active and unless we get a very strong bill to reduce nicotine and nicotine's availability and reduce the influence of the tobacco industry, we will be having a future with tobacco and nicotine. And as you say at the bottom there, how can people who are working against this rob them of their futures? And how can we who are working in this direction and need to have legislation, otherwise we are complicit in robbing children and adolescents of their futures. So the biggest thing that I'm going to start with is addiction and denial of choice. Nicotine is one of the strongest of all substances that are addictive. It's highly addictive and toxic. And if we look at the second of these bullets, the idea of a neuromodulator, that is not a neuromoderator, which sounds like quite a good thing in teenagers. This is a neuromodulator, something that actually changes the way in which the brain develops. And nicotine and the young brain, and I'll come back to what a young brain is in a moment, has potentially permanent effects on those young brains, affecting attention, learning, mood, and impulse control. So apart from being addictive and the young people want to come back for more nicotine and somebody's willing to sell it to them and they can still find it in South Africa, not too difficult, it's not too difficult to find it, they are also having their brains twisted by nicotine in this young plastic age of their brains. Linked to that is the next term on this slide, which is vasoactive. Vasoactive means it affects the way blood vessels flow. And in doing so, it can have significant effects on a number of organs of the body in these young people and will continue to have them for the rest of their lives. It's particularly problematic for a pregnant woman and the vasoactive nicotine affecting the blood supply to her baby, to her fetus that should be growing and has growth restriction by this action of nicotine. So who wants that in society in South Africa? I certainly don't. And I don't imagine there's one baby who wants to be born having been exposed to nicotine. We also know with nicotine that in the current uncontrolled environment of nicotine availability in this country, particularly through what are called electronic nicotine delivery devices. And who knows, somebody's probably thinking about nicotine pouches to bring into this country in some way. We really don't have control of this. We don't know how much nicotine is in there. And what we do know from other countries is that this is highly variable and potentially extremely toxic. And young people have ended up in emergency units just from using this equipment and getting huge hits of nicotine that aren't just a hit in an emotional way, but a hit in a physical way and potentially lethal way. And this is what I wanted to come back to about when is a brain developing. And really, the brain continues and is not to develop, is not fully mature until the early and mid-20s. So when we casually say the age of 18, we're actually not being scientific. We're not, when it comes to nicotine, we're not really thinking about the fact that people well over the age of 18 may be able to vote. But when it comes to voting to have nicotine, they're not actually voting because they don't really understand what they're up against in terms of nicotine. And to allow people to make it look pretty exciting and just what you want and what all your friends are doing, that is, well, here we are, put it at the bottom there. How can we knowingly deny young people choice by putting something in their brains when their brains aren't fully mature and saying it was just their choice? And I say young people, I'm not just talking about people under the age of 18. So just a word more about adolescence. We know that adolescence is a time of experimentation. And if we know that, we must make sure that things that young people want to experiment with are not available. So they can experiment with good things, like being kind to people and having a good time, but not having good chemicals. Because that is, particularly with nicotine, as I've said before, something where the experiment goes horribly wrong, and addiction, life addiction, which is extremely difficult to reverse. It's not impossible to reverse, and we'll probably talk about that a bit later, but we shouldn't start it with young people because the longer you've been on, the more trouble it is. And I just need to remind people who don't already know this, that the vast majority who get addicted to nicotine do it in their formative years, in childhood, in adolescence, and young adulthood. So if we can stop it at this point, we will have a nicotine-free future. We've got some evidence around these products from other countries that many young children will and teenagers and young adults will go for what are called e-cigarettes, but electronic nicotine delivery devices and other nicotine-containing products rather than tobacco. But in this country, they may start there, but tobacco nicotine is so much cheaper that it's very likely that they will slip over. We don't, as far as I know, and I haven't studied this in depth, we can maybe have that in the discussion, whether we're seeing that phenomenon in this country. What we also note is that just to allow these clouds of vapor to appear back in society when we got rid of this happening to a large extent in public places with tobacco products, this would be a step backwards and mustn't be allowed. And the new bill is designed to reverse this tendency, which is what we can already see happening around us. In America, the escalation of the use by young people of nicotine devices was quite appalling, to the point where they had to introduce legislation in a hurry. And I think we should take a little leaf out of India's book. India is battling with COVID at the moment, but they said none of these products will be allowed in their countries from the word go. And that seems to me a very sensible thing to have done. So, rounding off here, addiction and denial of choice. How can we knowingly deny young people choice not to be addicted to nicotine? So if we're looking at this rather bleak story of the future, when we haven't done what we need to do, which is to reduce tobacco and nicotine in our country to the lowest levels possible, then we are making our young people of this generation, this childhood generation and teen generation, we are, as we've already heard, reducing their lifespan and reducing the quality of life. If you have a heart attack, if you have cancer, yes, you may survive, but you're not the person you were, and the choices that you have in terms of optimal development and having a good life and enjoying your family and going out for a walk, all those things start to be reduced by the presence of tobacco and nicotine in society. You heard about 20% of cancers caused by smoking earlier. 40% of all cancers could have been prevented. That's a figure from the United States. And if you think of half of those could have been prevented with the absence of tobacco in people's lives, that is a major improvement in society's well-being and a huge reduction in the cost of healthcare in the country. So how can we let people destroy the years of good quality of life for the young people in this country by pushing the tobacco and sending up clouds of obfuscating smoke in society around what's true and what's not true? How can anybody do that? Can they look themselves in the mirror and say, I'm doing a good job of work today? Well, if they can, they ought to be going for counselling. So we heard about blocked arteries, the vascular disease. So blocked arteries can happen in the legs, in the heart, and to the brain. And these all lead to disability and a reduction in quality of life, an increase in the healthcare bills. And really, who wants a disabled grandmother or mother when you don't have to have one? So we need our children also to understand these things so they can help people to give up smoking and help their colleagues not to get damaged in this way. Take away the breath of their lungs, chronic lung disease as a result. So how can we knowingly squeeze the life out of them? This is a major problem from long-term tobacco use. And as we said before, starting early in life means that the longer time for the lungs to really be damaged. And in children, secondhand smoke from other people smoking has permanent lifelong effects on these young people, let alone the quality of life as a child, getting pneumonia, ending up in hospital, having asthma attacks where you don't need to have them. But all the way through life, these things are happening. And we now know that this is happening to the lungs of babies born inside women who inhale other people's smoke. This is just not acceptable. So we need to make sure that these kinds of things happening to growing lungs are not happening in our part of the world. And notice the word tobacco does not appear on this slide. This is what we're already knowing from electronic nicotine delivery systems. So don't experiment on South Africa's kids. Let's stop this in its tracks. So we don't want people cheating our children out of their futures from the time before they are even born that this is happening. So let's imagine a future without tobacco and nicotine across the whole life course, from a woman and a man deciding to have a child, all the way through the pregnancy, through the young life of that child, through adolescence and young adulthood to adulthood. No robbery, no kidnapping of these lives, no damage and destruction, no denial of responsibility by saying we didn't know that, no exploitation of young people, and no lying and stealing from the rest of the country. So I'm going to sing you a little song. I hope this will work. Here we go. Here I go. Imagine no tobacco, no nicotine. Everyone breathes easy. The smoke has been. Imagine all the people freed from durance vile. Oh, imagine a generation living in clean air. All of them protected, breathing in without fear. Imagine all the children are tobacco free. Oh, it's not that I'm a dreamer. but this is our appeal. Working all together, we can make it real. So here's some people who are making it real. Red Cross War Memorial Children's Hospital, even under the current legislation, has declared itself smoke-free. So let's get into getting this bill out of the parliamentary phases and through into law. It's good for everyone, it's good for youth, it's good for children, and it could go further than it does at the moment. So let's look at this bill through the lens of children's rights to survival, protection, and development throughout their lives. And with that, I say thank you.
Thank you, Prof. Westwood, for that live entertainment. Truly enjoyed it. And I think those words were quite profound. Thank you so much for all the information you've shared this afternoon, and we're right on time as well. So I also want to say, coming from the cancer arena and the cancer background, a lot of the clinical picture that Professor Westwood has painted and shared with us today, you know, we see that the impact of the disease firsthand, both from the communities we serve, the patients, the survivors in our care homes. So, Prof. Westwood, whatever you've shared, you know, we bear testimony to that. We can see it. And often, although we're talking about children, and what you know, a lot of your slides showed the picture about children, it's now, when the youth use the tobacco products, you may not see the impact immediately, but we see the long-term impact when we treat those patients and manage those patients as well. And also talking about secondhand smoke, you know, it's often, a lot of the organizations that are part of Protect Our Next get a lot of emails and communication from members of the public complaining about secondhand smoke. And it is really very, very sad that, you know, communities and the public do not respect that. And we truly hope through the legislation and through the new tobacco bill that there will be more protection for the people that can't have the voice to change the current situation. I just also want to remind our participants that there's a Q&A box. Please feel free to put in your questions, and either one of our panelists or someone will get to those questions through the box as well. It is my great honor and privilege to welcome the next speaker for this afternoon. He has been a mentor, someone that I have been truly inspired by throughout my 15 years in CANSA, and I'm so excited to be introducing him this afternoon. Dr. Yusuf Salaji has a wealth of knowledge and experience in tobacco control. For us, he is the go-to person. His work, his knowledge, his willingness to share is truly inspiring for many of us in the NCD arena. He is currently the Interim Executive Director of the National Council Against Smoking. He was previously its director for 28 years, during which time the Tobacco Products Control Act was passed in 1993, as well as several other amendments to the Act. He obtained his PhD from St. Bartholomew's Medical School in London, England. He will speak to us today about the history of tobacco control in South Africa. Thank you.
Thank you very much, Lorraine, for that very kind introduction. I appreciate your kind words. Let me try sharing my screen. Okay. Oh, there we go. Sorry about this. Okay, and there we are. Okay, what I really want to talk about is what can we learn from the past that we can apply to the future? And that's what I really want to focus on. Now, at the beginning of the 20th century, lung cancer was a very, very rare disease. In fact, most clinicians had hardly seen cases of lung cancer. And yet today, as Lorraine said earlier, lung cancer is the #1 cause of death in the world. Now, the deaths from lung cancer started to increase during the 1920s and the 1930s. And scientists both in the United States, the UK, and Germany asked themselves why. Why were we suddenly getting a rash of lung cancer cases and lung cancer deaths? And they began to investigate it. And what they found was reported in 2 medical journals, the Journal of the American Medical Association, JAMA, and the British Medical Journal. And both of them asked the question, what are the causes of lung cancer? And as Sir Richard Doll said in his paper in the British Medical Journal, that tobacco is a cause and an important cause of lung cancer. Now, in the 1950s, the word cancer was a very scary word. Usually when you were given a diagnosis of cancer, it implied that you didn't have very long to live. It was a death sentence. So many people assumed that once people were told of the link between smoking and cancer, and not just smoking and cancer, but subsequent research showed that it affected the lungs, the heart, and many other organ systems, that people would stop smoking. But of course, this did not happen, as we all know. In fact, quite the opposite happened. And global tobacco use went up. And this is because of the ingenuity of the tobacco industries. Sorry, I'm having a small problem going to, there we go. Okay. And this was because we didn't reckon with the tobacco industry. And on this slide, which is a very busy slide, but just look at the red line. The red line shows you cigarette consumption in South Africa from 1960 till 2020. And from 1960 till 1991, South Africa was like any other low-income country. Our use of tobacco went up and up and up. And then and that was the period of apartheid, and the nationalist government supported the tobacco industry. In fact, it protected the tobacco industry. And not surprisingly, cigarette use went up. Then in 1991, with the advent of democracy on the way, there was a slight change in government heart, and the government believed that if it took some measures to reduce tobacco or cigarette consumption, then the incoming ANC government would be too busy with other things to really worry about cigarette smoking. Of course, they calculated wrongly. But from 1991 till about 2004, cigarette consumption went down. And it went down very significantly because of the very strong measures enacted by the government, and in particular, Dr. Nkosazana Zuma, who passed health warnings, restricted smoking in public places, banned the advertising of tobacco products. And all of those things had a great impact on cigarette smoking in South Africa. Then round about 2002, 3, 4, the decline started to peter out, and then you see a continued decline in cigarette consumption. But that is a decline in the legitimate sales of cigarettes. It doesn't take into account the number of cigarettes that were being bought illicitly. And if you look at the number of cigarettes that are bought illicitly, then really from about 2004, 2005, cigarette consumption no longer continued to decline. Now, what were the medical consequences of this decline in tobacco use, and what will be the future consequences of the fact that cigarette smoking is no longer falling? These graphs from the Medical Research Council, the burden of disease study by Professor Debbie Bradshaw, shows that firstly, if you look at men, the smoking-related cancers, so these are cancer of the lung, cancer of the esophagus, and cancer of the stomach, all declined. But it didn't mean that cancer was falling, because if you look at cancer of the prostate, that increased. So it was only the tobacco-related cancers that declined and not other cancers. The picture is less dramatic in women, partly because women smoke far fewer cigarettes than men do. But we do observe some decline in cancer deaths the tobacco-related cancers amongst women, although on the other hand, breast cancer increased. To give you a larger idea of what the situation was, in 2000, the Medical Research Council conducted a study in which they estimated that 40,000 South Africans died each year because they smoked cigarettes. In 2016, a similar study was done, but the age range was restricted to those who are aged 35 to 74. And they found that 25,708 South Africans died each year from diseases caused by smoking. So, although we're not comparing apples with apples, what the slide does show is that tobacco use, diseases caused by smoking fell as tobacco use fell in South Africa. The government's policies to reduce tobacco consumption and the death and disease caused by tobacco were extremely successful in the 1990s and early 2000s. However, why didn't the government, if this was a successful campaign, that fewer people were smoking, fewer people were dying, why didn't the government continue with its program? Well, the real reason is reality got mixed up with myth. The reality is that tobacco causes health, economic, environmental, and social harm. But the tobacco industry put forward an alternative argument. The industry knew that it could not win the debate as far as health was concerned, that people knew that smoking was harmful and could cause disease. So the tobacco industry instead emphasized its role in the economy and that tobacco is good for the economy. But is that true? Is that really true? Well, let's just look at what the impact of tobacco is on our economy. Earlier this year, the University of Cape Town published a study, and in it they said that smoking costs the South African economy 42 billion rands each year. Most of those costs are because of people getting sick and being hospitalized, but also remember that smoking affects many people in middle life. So those people who get sick cannot go to work. Those people who die will no longer earn money. So there's also a loss of earnings. And of course, smoking is linked to poverty. People who don't earn money, people who can't work, will be thrust deeper into poverty. So this was the economics in terms of what tobacco does. And many people will say, yeah, but the tobacco industry pays taxes. Well, for every 1 rand collected in taxes from the industry, it costs the country 3.5 rands. It's a losing game. Smoking stunts economic growth. Of course, the tobacco industry will also argue that the tobacco industry provides jobs. Well, in fact, it doesn't. The World Bank has said that if the money once spent on cigarettes would instead be spent on other goods and services, this would create new jobs. And the reality is that if South Africans switch their spending from buying tobacco and cigarettes and vapes to spending it on other goods and services, you would actually create more jobs. Remember, cigarettes are made by machines. It's not labor intensive. Whereas non-smokers typically spend more money on education, food, facilities, utilities for the house, etc. These are labor-intensive things. So if we had a switch in spending from cigarettes and tobacco to other goods and services, we would actually create more jobs in South Africa. And I always remind people that smoking does not just kill. It also maims and leaves people unable to walk and talk and all the rest of it. So for every person killed by smoking, US data shows that 30 people live with a serious smoking-related illness. And beyond the statistics, we must never forget that there are real people who are being harmed by cigarettes, tobacco, and vaping. This person worked for the National Council Against Smoking. And what made him unique was he had cancer of the larynx. He had his voice box removed. And his name was Dennis. And for Dennis, even having a shower was dangerous. He certainly could not go swimming because water would get into his lungs and he would drown. This person had all 4 of his limbs, both his arms and both his legs, cut off because of peripheral vascular disease. And yet he was so addicted to nicotine that he's got his friends to take a wire coat hanger and make him an appliance so that he could continue smoking. There are also other people who've been affected, real lives, real tragedies. This person had a heart attack at the age of 45. Notice that many of the pictured people here are not old people. These are people in the middle of their lives. He had 6 bypass operations. She was 57, had a stroke, and she still has residual problems with her speech and her eyes. She was another person who had peripheral vascular disease. Her right foot, left leg, and several fingertips were amputated, and she was in her mid-40s. She had lung cancer when she was 52. This person had oral cancer at 43. Half her jaw was removed. And of course, as Professor Westwood has already said, the victims include young children. We know that if parents smoke, their babies are much more likely to die from cot deaths, etc. And this is a picture of a child who suffers from asthma triggered by tobacco smoke. But there is a happy fact. And the happy fact is that we have the tools to quickly and substantially reduce tobacco consumption. If the government looks at its own history and sees the rapid decline in smoking at a time when we took strong tobacco control measures, that should be the model for the government. And if we do what is in the bill, we will quickly reduce the numbers of people dying and getting sick from smoking. But more importantly, just as importantly rather, it also means that the National Health Insurance Scheme will be successful because the NHI will not be able to cope with the enormous burden tobacco throws on it. Lastly, what I would really like to talk about is South Africa used to be a leader globally, but especially in Africa, in tobacco control. We were way, way ahead of the game. But look at where we are now. This is South Africa compared to other African countries. There are 1, 2, 3, 4, 5, 6, 7, 8, 9 African countries which are totally smoke-free indoors. South Africa still allows smoking in indoor public places. If other African countries have seen the wisdom of protecting people from the dangers of smoking and protecting non-smokers, then why not South Africa? And I think on that point, I'm going to say thank you very much. Sharon.
Thank you so much. Thank you so much, Dr. Saluji. That was really enlightening. I think that what you've done is you've pretty much reinforced the foundation of the entire webinar, in that we had 2 experts who with experiential knowledge, but also expert knowledge. And so that expertise is so clearly conveyed in your presentations. So thank you so much for that. The next expert speaker, who also has a lot of experiential knowledge in the tobacco control work that she's done, is Zanele Mthembu. So let me introduce you to Zanele and tell you what Zanele's professional history is. Zanele has over 20 years experience in public and civil society sectors, mainly focusing on public health and policy development. Zanele worked for CANSA and then for the National Department of Health, first as Deputy Director and later as Director in Health Promotion. Zanele was involved in the first amendment process of the current tobacco control law and ensuring successful passage and implementation of the law, as well as representing South Africa in the international negotiations of the Framework Convention on Tobacco Control, popularly known as the FCTC. Zanele has represented our government and the WHO Africa region on international platforms and committees. Zanele now works as a public health and development consultant with organizations which include the Campaign for Tobacco-Free Kids, which is CTFK, the World Health Organization, the American Cancer Society, UNICEF, UNAIDS, and others. She's also pursuing further studies, and her research examines the social determinants of the use of e-cigarettes among the youth of South Africa. Zanele hopes to add insights into research and policy domains to strengthen tobacco control interventions in South Africa. We look forward to her insights now on the tobacco bill and how it protects our citizens. Thank you so much, Zanele. Over to you. Thank you.
Thank you, Pam, and thank you for the kind words. Good afternoon, colleagues. Can you hear me, Pam? Am I audible?
Very clear, thank you.
Okay, thank you so much. Yes, indeed. I think today it's actually a momentous day because I see even in the number of participants, we've got more than 80. That's a substantial number. And also that we're talking about an issue of particular importance, an issue that is close to our hearts, most of us. And I wish to thank my fellow speakers, Prof. Westwood and Dr. Yusuf Saloji, for their inputs. And I must say that my presentation follows from there. So there are issues that I would skip, particularly around the harm caused by tobacco, as well as other related matters that have been raised. And so, Chairperson, what I would want to do is to ensure that this becomes a conversation rather than talking too much, because I'm sure people got lots and lots of questions about the bill, the prescripts of the bill, and we are grateful that even the officials of the Department of Health are here with us. And so I have to start. And so I think for me, what we do need to know is the significance of this bill. What is the significance of this bill? Amongst others, and importantly, is that it addresses health and development. Without a healthy nation, there is no productivity. And so there also is no development. And so in that regard, it looks at ensuring that there's less tobacco consumption, we have a healthy nation and increased productivity and a healthy GDP in our society, which also means increased job creation. Also important to note is that our bill, it finds expression within some of the key international instruments. And of particular note is the United Nations 2030 Sustainable Development Goals. By the way, South Africa is a member of the United Nations, and which is why I'm bringing this forward so that we're able to locate our own bill beyond our own national prescripts. Within the UN SDGs in particular, goal number 3 talks about, it encourages member states of the United Nations to ensure that they promote good health and well-being by the year 2030, right? And importantly, within goal number 3, there are key important targets that relate to tobacco control. And our bill as well, it addresses exactly those targets. And I'm hoping by 2013, South Africa will be able to reach these targets. One, it's target 3.2, which talks about the end of preventable deaths. Prof. Westwood and Yusuf, they did allude, even you, Pam and Lorraine, you did allude to the fact that tobacco is the main killer and is the most cause of preventable deaths in the world. And so this target 3.2 also relates to us, tobacco control community. The second target is target 3.3 SDGs, it talks about ending the pandemics, TB and HIV/AIDS. And of course, I think, yes, I think I did hear my colleagues earlier alluding to this, that tobacco is also a risk factor. It actually contributes to poor health outcomes of TB and AIDS, regardless of whether the person is taking a medication or not. So the issue is about ensuring that we improve the health outcomes of people who have got TB as well as HIV/AIDS. And the most also important outcome, Pam alluded to this, is target 3.4, which is about reducing non-communicable disease burden and deaths. We do know that, and we have heard that tobacco use is also a major contributor of non-communicable diseases. And in South Africa, we have a problem of NCDs. And this bill drives home that message, and it aims to ensure that the NCD burden is reduced. Also, in South Africa, this bill has adopted a human rights approach. It's founded on the Constitution, and so forth. It aligns with the constitutional imperatives, our own Constitution of 1996. So if we look at the Bill of Rights, Section 2 of the Constitution, it talks to Section 24A in particular, and 24B. Section 24A of the South African Constitution, it accords the South African society, the South African population, a right to an environment that is not harmful to health or well-being. And Section 24B of our own Constitution, it's about the right to have an environment that protects the nation and also ensures the benefits, that it benefits the current and the future generations through reasonable legislative measures that aims to prevent pollution. I want to underscore that, Chair, that the bill talks about ensuring that the present and the future generations are protected from environmental harm by ensuring that there are reasonable legislative measures that will ensure that protection. And so it's clear, therefore, that our bill, it's not just a thumbs up. In fact, all South African laws, the 1993 and the amended versions, even the bill now, they subscribe to our own Constitution. Also, what is important is that the significance of the bill is that it addresses the health-related priorities of the country. And these health-related priorities are also enunciated in our own NDP, our roadmap, our developmental roadmap, the National Development Plan 2030. Within the NDP 2030 of South Africa, the health priorities that are espoused there, one, it's about the NDP ensures that by the year 2030, the life expectancy of all South Africans should be at least 70 years, right? Not this early death rate we are experiencing right now. And secondly, the NDP also ensures that there must be improvement in TB prevention and care. There must also be reduction in maternal and infant child mortality. We heard Prof Westwood talking about the impact of tobacco use and also e-cigarette use on maternal health, on infant health and child mortality, even unborn children, fetuses. And so this bill aims to address all those key aspects. Importantly, it also, as I mentioned, the NCDs, to reduce NCDs. So therefore, colleagues, it's not just a thumbs up, this bill, it's founded on our own principles and key documents. Now, so why is it important then for South Africa to regulate tobacco products and electronic nicotine delivery systems? And that is the name of the bill, by the way, is Control of Tobacco Products and Electronic delivery, nicotine and electronic delivery systems, which include both nicotine and non-nicotine, as well as heated tobacco products. It's important to note that the reason is that we are concerned. Our government is concerned about the number of deaths in South Africa. About 25,780 South Africans aged 34 to 74, they died early due to cigarettes. And of course, amongst these, about more than 700,000 people are living with tobacco-related illnesses. Yusuf has alluded to this, that it cost our economy 42 billion rands, according to the 2016 report by RIP UCT. It cost our economy 42 billion rands to treat tobacco-related diseases. And the health burden alone is about 14 billion rands. And that is enormous, enormous in a country that needs a health system that will be able to take on board and to ensure that the NHI is implemented successfully. And therefore the question, how can the NHI be implemented successfully in the midst of such a high burden of disease, which is also compounded by a preventable cause, which is tobacco use? And also, there are so many, I won't go through so many of them. And of course, the important one also is the need to reduce nicotine, particularly amongst the youth. And so this bill has been designed, has been developed because of the concern on the rise in nicotine usage. Also because of the introduction of the electronic nicotine delivery systems in our country, which are not regulated within the current bill. Also, we need to ensure the bill aims to ensure to protect public health and to promote the economy and environment, as well as the social aspects of our country. The 2018 bill, Tobacco Control Bill, is the fourth amendment. The previous amendments were effected because of problems that were experienced because of non-compliance by the tobacco industry, but also that has not stopped. This bill, therefore, has been the fourth round of amendments to give effect to the 2018 bill, exists to close the loopholes that have been exploited by the industry, particularly around marketing and advertisement. But also the industry continues to circumvent the current law, the 1993 Tobacco Control Act as amended, by introducing the nicotine delivery systems and non-nicotine and heated tobacco products. Also, the importance of this bill, why the current law was amended, is to ensure that South African tobacco control laws are in line with the Framework Convention on Tobacco Control, which South Africa ratified in 2005, and therefore we have an obligation to ensure that our domestic tobacco control legislation is aligned with this international instrument which we ratified. And also it aims to protect and promote public health. And so what are the key elements of this bill? I will not go into details about each and one of them. I would rather have questions from the participants so that we engage meaningfully and address exactly issues which people want to hear and want to know. But suffice to say that it's important for people to know that this bill, the key areas that are addressed is 100% smoke-free indoor public places. Prof. Westwood spoke at length about that, and also it regulates plain packaging or standardized packaging. It also about it bans the sale of tobacco products in vending machines, and it also regulates the electronic nicotine delivery systems. Now, regarding 100% smoking, 100% indoor smoke free public places, I need to emphasize that again because in the past few weeks, I noted there was an article about one of the members of the tobacco industry. They are poking fun and they are misleading the public. They say this bill aims to regulate smoking. There will be 100% smoking in public places. They deliberately omit in indoor public places. So I must emphasize, the 100% smoke-free relates to indoor public places, your restaurants, your bars, and so on and so forth, and other common places, common public places. And of course, the objective of this section of this principle is to protect non-smokers from exposure and risk associated with secondhand smoking. And that is in line with Article 8 of the FCTC. So the current situation in our country is that the current law which exists, the 1993 Act as amended, it allows smoking in 25% designated areas within indoor smoking places. And that is why when we go to restaurants or places like that, we see there's designation, you find there's a door, and they will tell you sometimes there is a sign on the door which says smoking areas. In certain places there isn't. And in fact, they are already defying the law, because the current law says any smoking area, any designated smoking area must have signage. So already the tobacco industry is not complying with it, and that is the problem. But also the other problem is that some of us have seen, have noted, when you walk into the restaurant or any place, you find that that smoking place, they open the door wide open. Sometimes it's not even closed, and the air and the smoke comes into the non-smoking section. And therefore, what's the point in having that designated smoking area if non-smokers will continuously be exposed to secondhand smoke? And we've heard about the dangers of secondhand smoke. I won't talk about the risks of secondhand smoke, but suffice to say that the secondhand smoke, it increases the risk of strokes by 20 to 30%, heart disease by 25 to 30%, breast cancer, obstructive pulmonary disease, and low birth weight in children. And that is according to the United States Department of Health and Human Services, the 2014 report. Of course, again, the other concern in South Africa is that 5 out of 10 leading causes of death in South Africa are associated with exposure to secondhand smoke. And therefore, it is important for government, and we applaud government for ensuring that secondhand smoke is regulated, this principle and this aspect to protect the citizens from the dangers, the harms of secondhand smoke is taken care of in the current bill. It's also important to note that we often hear there's an argument that smokers sometimes say it's their choice to smoke and so on and so forth. It's important to note, I mean, it's their right. There is no right to smoke. If we check the section 2 of the bill, the Bill of Rights, there is no right to smoke. Instead, there's a right to protect the public from the from exposure to secondhand smoke. So therefore, there's no right to smoke. Secondhand smoke, people smoke because of choices, because of addiction. Okay, and also this particular aspect of the bill, this section of the bill, it accords the citizen the rights, the constitutional right to that healthy environment. And we applaud this section, this solution by government to regulate. The other important section of our bill is that it regulates plain packaging or standardized packaging. It requires plain packaging or standardized packaging. Currently, there's a problem with packaging. As we can see, if we've noted tobacco packaging, the outside, it's colorful, it's designed in certain manner, and so on and so forth. And that creates a problem because there is evidence that those colorful graphics that we see in the packs of cigarettes and the logos and the trademarks and the every other image, they increase the appeal, particularly on young people, the appeal of the product. And some young people, they even have an emotional association, right? They develop an emotional association to those colors, to those graphics that we currently find in the packets of cigarettes. And therefore, it's important, it was important for government to ensure that all these graphics are removed. Of course, I've mentioned that it's also to destroy, to change attitude. Because of the association, it got to change attitude. And of course, science has revealed that in countries where plain packaging has been instituted, there has been a drastic reduction of smoking. In countries, for instance, like Australia, where plain packaging was instituted in 2012, and Australia is amongst the first countries in the world to do this. We do know that science reveals that there's been a progressive reduction of smoking prevalence. For example, we learned that from the studies that have been conducted, there has been a reduction of smoking from 16% in Australia in 2020 to 2012 to 14%. And amongst young people, there was a reduction, a significant reduction of up to 20%. And that is significant. And we look forward to ensuring that even in our own country, in our own shores, this principle and this aspect of promoting health and promoting the health of the nation is realized. Now, in South Africa, there has been studies conducted. There was one that was conducted by University of Pretoria, which aimed to determine the reactions of people on pictorial warnings and among students. And it concluded that the students responded positively on the pictorial warnings, and as opposed to just the letters, just the health or the writings. And so also the importance of the pictorial warnings is that for people with a low literacy rate, and we do know in our own country, we do have a substantial number of people that are not literate. And so therefore, if they are not catered for, and we say we want to reduce tobacco consumption, how on earth are we aiming to educate them about the health harms? And so this section addresses that exactly. And another evidence about the effectiveness of plain packaging comes from the from the UK in 2019 studies, which links plain packaging to the reduction in quitting smoking, and also the reduction in the appeal of smoking. We've got a lot of studies that are revealing the evidence in that regard. The next section is the vending machine. The bill, it regulates, it bans actually. It bans the sale of tobacco products and electronic nicotine delivery systems in vending machines. And that is in compliance with Article 13 and 16 of the FCTC. Now, the current situation is that currently the cigarettes are allowed to be sold in the vending machines, and the vending machines are allowed to be placed within the designated smoking areas. But what is the problem? The problem is that in some of these establishments, your hotels, hospitality, broad spectrum of areas, you find that sometimes the vending machines are not even placed in the non-smoking area. They are placed just in the open, where they can be accessed by anyone and everyone, including young children. And of course, the issue is that another concern is that if South Africa allows the sale of tobacco products in the vending machines, when the machine dispenses a cigarette or an electronic delivery product, it doesn't mind the age limit. Even a 5-year-old, they can throw in money in the vending machine and cigarette will come out. And that is a major, major concern to government and to some of us who are in the tobacco control space as tobacco control advocates. And of course, that is also tantamount to advertisement of tobacco products. And so what is the solution then? The solution is exactly what government has done to ban the sale of tobacco products in the vending machines. Of course, the other and very important aspect that is regulated is the nicotine and non-nicotine delivery systems, as well as heated tobacco products. I will not dwell much, Chairperson, on this because we have a particular section, a webinar, I think it's on the 27th of May, if I'm not mistaken, which is solely dedicated to electronic cigarettes. And so I won't talk much about that. Instead, I would urge people to attend that webinar so you hear more in-depth and elaboration of what are electronic delivery systems, what are the harms, and so on and so forth. But suffice to say, Prof. Westwood has already alluded to some of them, the addictiveness of nicotine. And the question really, do we want a future? Do we want the future generation that is so addicted to nicotine because of the tactics of the vaping industry, the vaping association, because of the tactics of the tobacco industry? Why shouldn't government legislate, regulate maximally, go beyond the minimum limit to regulate these products? It's important that happens, and we are happy that government has taken a reasonable step and effective step that is evidence-based, backed by science, backed by world bodies like the World Health Organization, backed by so many other studies that have come up. And I think what I need to mention is also that studies throughout the world, they are also showing that e-cigarettes are actually a route to smoking for the youth. What do I mean by that? Studies indicate that the youth that were non-smokers before the introduction of e-cigarettes and heated tobacco products are now smoking. They've now started smoking. Why? Because the industry glamorizes these products. You will see some of you have noted them. I don't have the slides right now, but you've seen them, how they're glamorized, the look and feel of this product. It's so glamorous, it's so cool, as the youth says. And so therefore, it appeals to them. That is why most of them end up smoking these products. However, again, the industry says they market these products as smoking cessation aids. There is ample evidence, even in our own country, a study released in March, conducted by UP, MRC, as well as SMU, reveals that e-cigarettes, people who are using e-cigarettes as a smoking cessation aid, there is a higher number of relapse. They will stop smoking, but in 6 months, between 6 months and 9 months, they relapse and go back to smoking. And when they go back to smoke even the traditional tobacco products. And so therefore, what is the point in allowing these products? And important also to note that these nicotine products, they are not registered in South Africa. And then they are not registered with the South African Health Products Regulation Authority, or former MCC. And so therefore they cannot be sold as a smoking cessation aid. WHO recommends that any product that is used as a smoking cessation aid, it must be registered and must be in line with the safety measures. And let me conclude. I see I'm out of time. So in conclusion, we say that the South African tobacco products and electronic delivery systems has adopted the right approach based on protecting the rights of the citizen so that they are not exposed to the harms of tobacco, particularly secondhand smoke. Importantly, it also accords the youth the protection from the unhealthy environments, and also that it promotes the health and well-being as in the Sustainable Development Goals. And also our bill, it also aims to save lives and the health systems. We know our health system is already inundated, and this supports the implementation of NHI. NHI will thrive if there's reduction in consumption of tobacco control. Now, of course, our economy and the environment will also thrive because we'll have less people smoking. If there's less people smoking, there are improved health outcomes. If there's improved health outcomes, there's improved productivity, less people are sick, less people are absent from work, and the economy will thrive, there'll be more jobs, and poverty will be reduced. Thank you, Chairperson. I will leave it there, and I'm happy to take questions.
Thank you so much, Zanele. That was such a good, comprehensive overview. I think it was really well presented in the sense that you talked about the actual evidence that is sort of unquestionable evidence and how it links to what's being proposed in the bill. But you also made reference to emerging evidence, which is critically important. I guess that also pertains, the emerging evidence will pertain more towards your electronic devices and so on. But regardless of whichever way you want to look at it, the reality is there's more than sufficient evidence to tell us that we're approaching the bill in the correct way. Also because the pillars of the bill are very much aligned with the FCTC as proposed by WHO. What I'm going to do at this point, so thanks again, I'm going to, so, you know, our consortium of mobilizers for the tobacco bill, we've also interviewed the members of the public, and we're going to share that video with you in a minute or so. But I just want to reassure the people that have attended, the participants, that we have seen your questions. They're in excess of 35 questions already. A lot of the questions obviously overlap, and there's sort of common themes that run through the questions. We will try and, I think we're due to knock off at about 4:30, but we will definitely try and address some of the questions that have been asked. But shall we have the video first, please? Thank you.
And I find it really awful to have cigarette smoke drifting past me while I'm doing my morning exercise. So what is the legislation pertaining to that? I'd like to know about smoking in complexes, because in the morning I do yoga on my bed, and the neighbor is always smoking at that time, and I find it really awful to have cigarette smoke drifting past me while I'm doing my morning exercise. So what is the legislation pertaining to that?
Okay, I guess in the interest of time, we've just had the one commentary from the public. But so when one looks at all the questions that were submitted, they definitely cluster around a few issues. Primarily, it was around the electronic devices as an alternative to tobacco cigarettes, cigarette smoking. And also the value of electronic devices for harm reduction. So that was the one, quite a number of questions asked around that. There was also an interesting question and a commentary around the World Health Organization controversy by suggesting the FCTC, but suggesting that they've taken funding perhaps from the tobacco industry. The third cluster of comments and questions was really around the economic consequences of stopping the industry, the tobacco industry, very similar to the arguments we heard for the sugar sweetened beverage tax, and that is loss of jobs, both for the tobacco industry directly as well as for the electronic devices industry. And then the next set of questions was around the comparison between limitations on alcohol versus limitations on tobacco versus limitations on electronic devices. What I would like to do, the approach I'd like to take is for me, Prof. Westwood, if you would please, if you want to maybe comment or attempt to answer, I'm hoping you also had a squiz at some of the questions. If you're able to, and then I'll go to Dr. Saluji, and then I'll go to Zanele Mtembu as well. And yeah, and then we can see if there are other panelists who would like to comment as well. Thanks, Prof. Westwood.
Well, thank you very much. I would like to comment a little bit about the electronic devices. I think that as far as children are concerned, there can be very little extra that hasn't already been said around tobacco itself. So some of the questions have been around other devices. I will not talk about this term harm reduction. I don't know that we need to go there. What harm reduction we could have is to not have nicotine in these items at all. There can be no reason to have them unless they were medical devices given to people on prescription by a doctor to look at, once the evidence is out, and the evidence is still very equivocal as far as I can see, that they might add to the list of things that we have to try and help people who smoke tobacco-related products to come off those, which we certainly want to give them every opportunity, but we do need the evidence. There are good products out there already that's the case. But in general, I think that this bill does not ban them, which is actually a bit of a surprise, because they really don't have any value in terms of children and putting nicotine into society. And if they were only for harm reduction, they wouldn't be advertised for children. So I think that if there was a genuineness about this, then the nicotine wouldn't be in these products except as medical devices going through SAPRA. And this the second, so I think the bill meets that head on to say that there's something that needs to be controlled here in terms of safety and access. So that would be the case. I think we also need to know that many animal studies are being done on what comes out of various electronic nicotine supplies in terms of what they're doing to the lungs. And I put that on one of my slides. And there is no reason why we in this country would want somebody to be starting these things early on, where it's not even harm reduction because they've never had anything else in their lives, and then saying, well, now you're addicted, now let's see what happens to your lungs in 20 years' time. That is not a future we need. So that would be my perspective on that. We don't need nicotine in those things. We need nicotine. If we need it at all, it would be a medically SAPRA-approved evidence-based reason for that. So that would be my comments to what I've seen so far. Thank you.
Well, thank you so much indeed. I think absolutely 100%. You know, my own background is in mental health, and if it does have a place in harm reduction, electronic devices, but it's got to be part of the treatment regimen, you know, and control so that there's no medical harm to any individual. But so thank you so much. Dr. Saluji?
I'd just firstly like to respond to the question about neighbors smoking and that affecting people. As far as I know, the bill as it was gazetted in 2018 did not restrict smoking in apartment blocks and where you have shared neighborhoods. So this is an area that the tobacco control community really needs to mobilize and get the bill to recognize. And I've had many complaints from people. I've just come home with my baby and smoke is coming from the neighbors into my baby and affecting my baby. Also, I've got asthma and it's been provoked. So we really need to make sure that the law protects people. Then we have a right, a right in our constitution to an environment that is not harmful to the health. And that brings me to this issue of many people on the questionnaires saying, what about people's rights? What about our right to psychological integrity, etc.? Now, I think these people are really living in cloud cuckoo land. They forget that nicotine is an addictive substance, that people begin addiction as children before the establishment of mature adult judgment. And the tobacco industry has known, and I include the vaping industry in this, that if you can get a child to experiment with cigarettes or vaping, then nicotine addiction will ensure that they have a customer for the next 40 years. So really, we're talking about people benefiting and profiting from exploiting children. And once adults become addicted, it's very difficult to stop. About this harm reduction argument. So let's examine this harm reduction argument. People say that if people smoke, use electronic cigarettes instead of using cigarettes, they'll reduce the harm. The evidence from the United States and from the United Kingdom and the UK is promoting e-cigarettes very strongly, shows that almost half of adults use both e-cigarettes and continue to smoke, so-called dual use. And dual use does not reduce the harms of cigarette smoking. As Zanele has said, that the latest evidence, it's a meta-analysis of 27 studies. So this is scientific evidence. These people have been talking about the science. A meta-analysis of 27 studies in the UK show that children who were not smoking, but who experimented with e-cigarettes, later on went on to smoke cigarettes. Now, this might have something to do, as Professor Westwood said, that cigarettes are much cheaper than e-cigarettes, and therefore they graduate from smoking e-cigarettes, they become addicted to nicotine, and they continue their nicotine addiction by buying the cheaper form of tobacco product. So unfortunately, despite the many questions which the vaping people have put onto this thing, there really isn't a leg to stand on. The bill makes sense and it protects public health. Thank you.
Oh, sorry, I was on mute there. Thank you so much, Yusuf, much appreciated. I'll go to Zanele. Thank you, Zanele.
Thank you, Pam. I think it's important that we underscore the evidence that is before us. There's no doubt, there is just no doubt about the evidence that we have about the harm caused by tobacco and on the environment, on the health, as well as on the economy. I mean, the issue of, I think you spoke about, there's a question about economic consequences. Actually, there is more economic burden on the state than on the tobacco industry. Because if they pay 20 billion rands in taxes and VAT, and government spends 47 billion treating tobacco-related diseases, as well as due to loss of productivity. So who pays more? Who pays more? Who is spending more? And so our money, we who are non-smokers, we have to demand it from the tobacco industry by ensuring that we support this bill. And this bill becomes a reality because it's a bill that aims to protect and promote public health. But also, I think it's important to note, to say that also to underscore the fact that this bill is founded on the Constitution. So its government is acting on her constitutional imperatives to ensure that the public is protected. And so therefore, whatever narrative, we know the narrative of the industry, the objective of the industry in any case is to profit at the expense of the health of the nation, regardless. And that is what they're pushing right now with all the evidence, with all their tactics. And therefore, we should not back off, and we should not be persuaded by their narrative, because they twist facts, they twist evidence. I mean, the issue that you raised, Pam, about WHO, I mean, what did you say? They say WHO has taken money from the industry. That is absolute nonsense. I mean, I can say that I'm not WHO, but I can tell you it's absolute nonsense. There is no such. WHO can never do that. So in closing, I think it's important. I do want to say, from now henceforth, we really are looking forward to the bill moving with speed to cabinet and to parliament and to the implementation process, because so many advocates that are part of this meeting, they may not have been speaking today, but we do know the passion and the dedication they have to ensure that they galvanize support for the bill. And I suppose the department is listening. We are so many people who want to ensure that this bill passes and the society knows about the harms and the importance and the evidence that is founded on this bill. And so therefore, on that note, I wish to say thank you very much, and we look forward to the bill. Hopefully in the next few, should I say months or years, being passed.
Yes, yes. Thank you so much, Zanele. Thanks again to all our speakers. Look, I think it's such a complex issue, but we come down to the same thing though. The common factor is that it's harmful. And so I think that the argument that I've also been following in the Q&A group, in the chat function, is this individual right to choose versus, population health. And I think that for those of us who are, championing the cause, we are certainly approaching it from a population health, public health perspective. So unfortunately, time has got the better of us. So before I ask Lorraine perhaps to also say goodbye to everyone, I just want to remind everybody about our webinar series and also the Tobacco Control Champions sign up. Please go to www.protectournext.co.za for more information and follow at Protect Our Next on social channels for news, views, and events. Lorraine, do you want to say a final thank you? Thank you again also to all our attendees. Lorraine?
Thank you, Prof. Yes, thank you to our panelists and our participants for the interesting questions. I also want to just say, as organizations working in the non-communicable disease arena, it is our responsibility to educate the public in terms of the risk factors associated with the diseases. And also to just tell participants that we do have support programs in terms of quit smoking. The National Council Against Smoking has a quit line. They can look at it at the website. And also the Cancer Association has the e-Kickbutt program, which is an online system available to the public, which has benefited many individuals. So yes, if you are wanting to quit, please do access those sites for more information. Thank you, everyone.
Thank you all and goodbye. See you next time.
Thank you.